All right, let's talk about IV fluids. They are, without a doubt, one of the most common things you'll ever prescribe in a hospital. But getting them right, that's a whole other story. Knowing which bag to hang and when isn't just some basic skill. It's absolutely critical. And honestly, it can be the one thing that stands between your patient stabilizing and them, well, crashing.
So picture this. It's 3 in the morning, your pager just goes off, and it's that sound you dread. Your patient is crashing. Their blood pressure's in the boots, the heart's racing to keep up. You have to move, and you have to move now. The bag of fluid you grab in the next 30 seconds could literally change everything. So, what are you reaching for?
And that is exactly why we're here today. See, this isn't just about simple plumbing, filling someone up with water. This is about physiology. The right fluid choice buys you precious time. It stabilizes your patient. But the wrong one? It can send electrolytes into a tailspin, it can flood the lungs, it can even cause brain damage. Yeah, the stakes are that high.
So, to make that right call under pressure, you first have to know your tools. Let's pop the hood and take a look at what's actually inside these bags. Let's understand our toolkit.
Okay, so broadly speaking, we've got two main categories. Over on the left, we have crystalloids. Think of these as solutions with small molecules, things that can easily slip from your bloodstream out into the body's tissues. These are the absolute workhorses of fluid therapy. You're going to be using these 99% of the time. Then on the right, you have colloids. These have big, chunky molecules like albumin that are too large to get out of the blood vessels easily. They act like little sponges, holding fluid inside the circulation. They're powerful for sure, but they're really reserved for very specific situations. So for our purposes today, we're focusing on the workhorses, the crystalloids.
Now, if there is one concept you need to burn into your memory, it's this one: tonicity. This one idea drives almost every decision we make with IV fluids. Tonicity is just a fluid's ability to make water move across a cell membrane. Get this right, and you're supporting the body beautifully. Get it wrong, and you can cause cells to swell up and burst or shrivel up like raisins. So yeah, understanding tonicity is the absolute key to all of this.
And here they are, our main tools, all laid out. This is basically your cheat sheet. You've got your isotonic fluids at the top, Normal Saline and Lactated Ringers. These are your go-tos for resuscitation. Then you've got hypotonic saline, or half-normal saline. We use this to give free water to dehydrated cells when there's too much sodium around. And then, at the very bottom, the big gun, hypertonic saline. This is a high-alert medication we use to literally pull water out of swollen brain cells. But look closely. Every single one of them has a key warning we have to respect.
You know, to keep all this straight in our heads, we can break down all IV fluid therapy into 3 pretty distinct phases. First, you resuscitate the patient who's actively crashing. Second, you replace any deficits they might have. And third, you provide maintenance fluids for the patient who just can't drink. Just remember, resuscitate, replace, maintain. Let's walk through each one.
First up, the most urgent phase, resuscitation. We're back with that patient at 3 a.m., the one in shock. This is not the time for fine-tuning. This is all about rapid, life-saving action.
The goal here is simple, and it is singular. You need to rapidly refill the volume inside the blood vessels. That's it. You're trying to get their blood pressure back up and get oxygen flowing to their vital organs again. You are quite literally refilling the tank. And the tool for this job? It has to be an isotonic crystalloid. That means either normal saline or lactated ringers. We pick these because their salt concentration is super close to our own blood. That means the fluid will actually stay inside the blood vessels where we need it, expanding the volume without causing crazy fluid shifts in and out of the body's cells.
So how much are you giving? Well, you're not just trickling this stuff in, you are giving a bolus. For most adults in shock, you're going to start with a rapid infusion of 1 to 2 liters. You hang the bag, open the clamp wide open, and then you immediately reassess. You're looking for a real tangible improvement. Is their blood pressure coming up? Is that racing heart rate starting to come down?
Okay, so the immediate crisis is averted. The fire is out. For now, the patient is stable. But our job's not done, because the problem that caused the shock in the first place is probably still there. So now we move into phase 2, the replacement phase.
Replacement therapy is all about zeroing in on and correcting a specific deficit. Sometimes it's a straightforward volume problem, like from dehydration. But other times, it's a more complex issue with a solute, and 9 times out of 10, that solute is going to be sodium.
And this slide really nails the 2 big sodium problems we face. On the left, you've got hypernatremia. That's too much sodium. This makes the blood hypertonic, and it literally yanks water out of your body's cells, causing them to shrivel up. On the right, hyponatremia. Too little sodium. This makes the blood hypotonic, and it causes water to rush into the cells, which is especially dangerous when those cells are in the brain. So how do we fix it?
Well, we basically fight fire with fire. For hypernatremia, where the cells are all dried out, we give a hypotonic fluid to gently push water back into them. And for severe hyponatremia, where the cells are dangerously swollen, we give a very carefully controlled dose of hypertonic saline to pull that excess water back out.
And that brings us to our third and final phase, maintenance. This is for your stable patient, the one who is NPO, can't have anything to eat or drink, and just needs some basic fluids to cover their daily needs.
So how much do they need? Well, the classic formula that we all learn is the 4-2-1 rule. It's pretty simple. You give 4 milliliters per kilo per hour for the first 10 kilos of body weight, then 2 milliliters per kilo for the next 10 kilos, and then 1 milliliter per kilo for every kilogram after that. So for a 70-kilo person, that's 40 plus 20 plus 50, which comes out to about 110 milliliters per hour. It gives you a really solid evidence-based place to start.
And what fluid do we usually use for this? A super common choice is D5 half normal saline. It's a hypotonic fluid that gives the patient both water and a little bit of salt. The D5 part is dextrose, and it's in there to provide just enough calories to keep the body from breaking down its own muscle for energy. And yet we almost always add in some potassium because our kidneys are really good at getting rid of it, even when we're not eating.
Okay, let's wrap this up with some super high-yield clinical pearls and pitfalls. These are the things you absolutely have to know, not just for your exams, but for keeping patients safe on the wards. First up, Normal Saline. You know, it's not as normal as the name makes it sound. It has a way higher concentration of chloride than our blood does. If you pump in huge volumes of it, you can cause something called a hyperchloremic metabolic acidosis. This is a classic board exam question.
Second, lactated ringers. It's considered a more balanced fluid, which is great, but you have to remember that it contains potassium. So you've got to be really careful about using it in any patient who already has high potassium or in someone whose kidneys aren't working well enough to get rid of it.
Now, when it comes to fixing sodium problems, the timeline is everything. You have to remember this mantra. If the problem developed fast, you can fix it fast. But if it developed slowly, you absolutely must fix it slowly. This is a non-negotiable rule to protect the patient's brain.
And that brings us to the complication that every doctor fears. If you correct a chronically low sodium level too quickly, you force water out of the brain cells way too fast. This causes a devastating neurological injury called osmotic demyelination syndrome, or ODS. The rule is simple and it is life-saving: go slow.
So, there you have it. You've got the framework: resuscitate, replace, maintain. You know your tools, and you know the major pitfalls to avoid. The real art of medicine, though, is applying these principles to complex patients. How do you adjust your plan for a patient with heart failure who can't handle a lot of volume? Or what about a patient in DKA who is profoundly dehydrated but also has wild electrolyte swings? Answering those questions, well, that's where you go from just knowing the rules to becoming a true clinician.